Session on respiratory symptoms virus. So we can start with sir's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. We can have our case presentation by 4 o'clock, followed by its discussion. We can wind up our session by 4:30. So thank you all for joining in. Over to Dr. Sona.
Good afternoon. So we have another important session, which is a very common symptom in patients in palliative care. Not only in patients in palliative care, but also in other specialty care. We'll see many patients with breathlessness. So this session will be taken by Dr. Pankaj. Dr. Pankaj is an assistant professor in palliative medicine at KMC Manipur. He has done his MD in palliative medicine from Tata Memorial Hospital. And Dr. Pankaj, it's over to you.
Yeah, thank you, Dr. Sunil. Good afternoon, all. This you are sharing my PPT.
Yes, sir.
Yeah, I can share through my desktop. So
Okay, sir. You can share it.
Yes. Okay. So today we will be talking about palliative care in respiratory diseases. Okay. It's one of the most common symptom, and it's very difficult to address this symptom in advanced malignancies or other diseases with these respiratory symptoms. So what all things we will be covering today. Can you see my screen?
No, sir, we can't see it.
1 second. Okay, is it okay now?
Yes, sir.
Can you see? Yeah. So the most common symptom is dyspnea, that is like breathlessness or shortness of breath. Other common symptoms that we will be discussing will be the cough, hemoptysis, respiratory secretions, or death rattles. Palliative care commonly seen in respiratory diseases like end-stage COPD, commonly in the lung cancers or lung metastasis of any malignancy, end-stage heart failure, severe pulmonary artery hypertension. Very commonly nowadays in interstitial lung diseases when they are oxygen dependent and find it difficult to do the activity of daily living. In occupational lung diseases like silicosis, pneumoconiosis, and motor neuron diseases where they feel it difficult to
Can you make your PowerPoint in full screen view?
Is it not? You are not
It is
able to see.
editable mode now.
1 second again. Just a minute.
Yeah, that's it.
Sorry. Which screen you are able to see now?
It's in editable mode now. Just click on the F5.
F5. Yes.
Yeah.
That's okay now?
Yes, sir.
Okay. Yeah, so we were discussing these all are the common diseases where the role of palliative care are there, or mainly the respiratory symptoms are present in these diseases. Okay. So first of all, we will discuss about the breathlessness. Commonly in the medical language, we call it dyspnea. Patient usually present like shortness of breath or not able to breathe or any choking sensation or hunger for air. These are the common terms they use. By the definition, it's defined as a subjective experience of breathing discomfort. It may vary in the intensity or like how they present. They may have their own distinct sensation. So how do they get breathlessness? So for that, we have to understand the physiology of respiration or breathing. Uh, this is a very simplified diagram to understand breathing or breathing mechanism. What happens, like in our respiratory system or in lungs, airways, in face, there are multiple receptors. We usually classify them either the mechanoreceptors or chemoreceptors. These are usually the nerve ending. So mechanoreceptors are present in alveoli, in airways, small and large airways, and on the face also, uh, and the face, in the nostrils. So and these all are receptors of free nerve endings. And there are chemoreceptors that is mainly present in the aorta, atrium, and carotid body. These, whenever there is less oxygen in the chest, or when there is increased requirement, or whenever there is high CO2 in our blood, these chemoreceptors usually perceive that there is an increased need for respiration. They send their signals to mainly to the brain stem, to the medulla oblongata, and also there may be some afferent sensation to the cortex. A brain stem in the medulla oblongata, whenever the increased need is there, it increases our breathing pattern, it increases the respiratory rate, it can dilate our small airways, and also expansion of the alveoli. So, if a person is doing exercise, or is at a very high altitude where there's less oxygen is there, these things through the mechanoreceptors and the chemoreceptors, they send the impulse and the stimulus to the brain. Here the role of cortex is also important, because cortex also give means through the medulla oblongata, it's an autonomic reflex, it's there, but sometimes the cortex by themselves, by the voluntary effort, it can also increase or decrease uh, 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 the respiratory requirement. So when do we feel breathless? Whenever there is very increased ventilatory that is demand, like our ventilation has to be increased. That's very common whenever we do exercise, or whenever we like run, or going uphill. That time usually our ventilatory demand increases, or whenever there is an impairment in mechanical process of ventilation. So many times we are not able to breathe properly. It can be because of any reason. There may be a skeletal reason, the muscles are not proper, or patient is not able to breathe, or there is not adequate lung volume is there. So those causes we will discuss later. So this was in brief, or in simple way, the pathophysiology of uh, dyspnea. This is especially important when we will be discussing about role of morphine or opioids in breathlessness. So, in these diseases, how common dyspnea is? Like in lung cancers, it is around 60 to 95% of patients feel breathless. In heart diseases, around 60 to 90% also in advanced heart disease. In advanced COPD, most of the patients complains breathlessness almost all the time, just 90 to 95%. In CKD also, because patients get fluid overload, pulmonary edema, they complain of uh, breathlessness. Many times they come to hospital only because they feel breathless and they want to get dialyzed. In motor neuron diseases, because the ventilatory system is not proper, they feel muscle fatigue, and there are chances for aspiration, so they feel dyspnea. In stroke, around 35 to 40% of patients. Dementia, again, they feel difficulty in breathing in, and also the chances of aspirations are quite high in dementia, and that's why they get the breathlessness. In HIV and AIDS, uh, because of opportunistic infections, it can increase further. Assessment. So, how do we assess breathlessness? There are 4 things we usually assess. Okay, can I take a minute break? Please? Yeah, sorry. So where were we? We are like assessing the breathlessness. So it is like in 4 major domains we assess. So first is quality. What quality of breathlessness they complain of. Uh, Usually, as I said, that there may be air hunger or unsatisfied inspiration. They say that air is, we feel thin air or short of air. Other is work or effort. They have to give more effort to breathe in. And third is tightness. They feel the chest is constricted. So these are main qualities. And then impact. So what is impact of their breathlessness? It can be on the prognosis. Whenever they feel breathless, they think like uh, disease is increasing, or is it a sign of death, or their distress increases. They feel our prognosis is not good. Psychological distress and social distress. Because of breathlessness, they are not able to do most of their activities of daily living. Uh, they are not able to go outside. They are not able to do. They are not able to communicate with other people. So these may be the impact of breathlessness on them. The distress also. So distress usually we measure by the cancer dyspnea scale. So out of 0 to 10, how severe the breathlessness is, or what kind of unpleasantness they are feeling. So how severe, that is the distress or severity. And then symptom intensity. So or the burden of the disease. So this we can use different quality of life skill, or the commonly one that we use for the severity or intensity of breathlessness, that is MMRC. So what is MMRC? MMRC is Modified Medical Research Council Dyspnea Scale. It is from 0 to 4. So 0 here is breathlessness, that is on the strenuous exercise, like it is normal for all. Whenever we do strenuous exercises, we feel breathless, that is normal. 1 is shortness of breath when we are walking hurriedly or walking uphill, that is grade 1. Grade 2, these people they feel breathless even on walking for few steps. How do we note it? Like if they are walking with people of same age, they have to slow or stop after some time. Then 3, they cannot walk more than 100 yards without being breathless. And 4th is they are not even able to leave the house, or they are not able to do activities of their daily living. So this was about the assessment. What are common causes of breathlessness in our setting? Anybody would like to tell? Okay, so we will come one by one. In cancers, what are common causes of breathlessness? Like lung cancer, their lung parenchyma may be decreased. There may be obstruction to the airways. There may be infections that is causing the consolidation and again decrease in the lung parenchyma. Extrinsic, there may be some obstruction that is compressing the airways, or maybe pleural effusion that can cause uh, breathlessness. Other than lung causes, there may be cardiac causes, renal cause we discussed right now. So the cardiac causes may be like end-stage cardiac failure. It can be. There may be cardiac diseases, cardiac rhythm diseases that can cause. In skeletal disease, there may be severe kyphosis or scoliosis that causes trouble breathing. So these are the common causes. How do we manage breathlessness? We will talk about the palliative approach for breathlessness. So our approach should be first on the rehabilitation of the patient. So that involves the minimal to minimize the production of symptoms. How do we do? Like we give supplemental oxygen if patient is hypoxemic. There are some breathing techniques like breathing, pursed lip breathing, and there are relaxation exercises. Patient can count from 1 to 3 and breathe in, then hold for some time, and then again by the count of 1, 2, 3, 4, they have to expirate. So that those are few relaxation exercises that they can do. Many times the patient is so sick that they are not able to expectorate the sputum, and that causes congestion in the chest. So some chest physiotherapies that are required. Important nutrition, especially in the patients with MNDs and stage COPD, where the work of breathing is quite high. There we need to give good nutrition for the patients also. Then, so this was to minimize the production of or presentation of the symptoms. Then comes the to reduce the impact of symptoms. So how can we reduce it? So one is the energy conservation thing. It is also same for the fatigue also. So we tell them to delegate their work appropriately. Whenever whatever is most important for them, and where the energy requirement is lesser, that they can do. Many times patient is not breathless all the time. In a particular time in the day they feel less breathless, and maybe in the evening or the morning they feel more breathless. So they can do their activities whenever they feel less breathless. And also they should not do those activities which makes them more breathless, or they can appoint any other person for doing those exercises. Posture and ergonomics. So we know like many patients have dyspnea on lying down. They feel more breathless when they lie straight. So maybe propped up position for them. Many patients have a lot of secretions. They are not able to clear it out. The sometimes lateral position, or even in patients with malignancies, the tumor compresses the airways, and in the particular position they feel less breathless. So the posture, adequate posture is important for them. Lifestyle modification, again they should not do the strenuous work, and to minimize their activity, we can do the lifestyle modification. Whenever needed, they should use the wheelchairs. And what should we do when this breathlessness increases? So action plan for the exacerbation. They should have oxygen cylinders or any nebulizer at home if they feel wheezing or breathlessness increases, especially in COPD patients. If we anticipate that his breathing, his breathlessness may increase, we have to give them those options of SOS morphine also, or where they can go the nearby healthcare facilities in such situations. Many times we have to discuss about their resuscitation preferences or preference for intubation and ventilator support, especially in patients with advanced malignancies or heart or lung diseases, because as the disease increases, their requirement may be there, and if they don't have they haven't discussed their preferences, it may be difficult for the healthcare team. Okay, then last comes approach for palliation by the management, like pharmacological management. So what are the common medications we use? First of all, like oxygen, if patient is hypoxemic, many bronchodilators we use in such patients. Opioids are very commonly used in the palliation. Steroids, inhaled steroids and systemic steroids that are used. So we'll come for the pharmacological management. So this is the step ladder for dyspnea management. Like first we use bronchodilator if there is any bronchospasm is there or wheezing is there. And we around the clock we use the long-acting bronchodilators, and whenever there is intermittent increase in the breathlessness, we use short-acting bronchodilators. Many times combinations of these drugs are also used. So these can be given as either inhaler or as a nebulizer according to the patient. We have to give adequate exercise training for them, and whenever required, the supplemental oxygen. On bronchodilators and adequate training, if dyspnea persists, then we should use some pulmonary rehabilitation methods like pursed lip breathing. Very important, fan, the table fan they keep near the face, and the gush of air decreases the perception of breathlessness. Many relaxation techniques that I told can be used. Then comes the palliative pharmacological measures. So most important thing is adequate use of morphine, and whenever needed, anxiolytics, and that is used. Okay. Uh, so here we were discussing what all are the measures to decrease the breathlessness. So one, oxygen. Oxygen in patients with hypoxemia. Again, if it is less than 90%, then oxygen may help. Usually the nebulized oxygen should be given. How does it work? It increases the saturation, the gush of cool air over the face. Also give the soothing effect for the patient, and also it stimulates the mechanoreceptors or nerve endings on the face. It is a medical symbolism, like they are getting the treatment, and very commonly in the movies and everywhere we see like patient is on oxygen. So that is a medical symbolism for them. Then comes the benzodiazepine. Benzodiazepine used in breathlessness is quite controversial. Uh, how does it work? It works by reducing the anxiety, anxiolytic action. The thing is like more opioids and benzodiazepines, the combinations is usually not preferred, but if patient is very anxious and that is precipitating the breathlessness, we should use the benzodiazepines also. Usually we prefer the midazolam, but if patient is mobile and has profound anxiety, some longer acting can also be used. Mainly for breathlessness, it is shorter acting is used. The bronchodilators, so there may be bronchodilators, oral bronchodilators can be used, or through the nebulized form or IV can be used. So oral bronchodilators, any examples can you give? Okay, so filins, theophylline that we use, and darifylline very commonly used, doxophylline that can be used, methylxanthines, beta 2 agonist like salbutamol that is used orally and also in inhaled form. Diuretics like furosemide that is used, Lasix, if there is pulmonary edema, signs of pulmonary congestion are there, then we can use diuretics also. Some studies or in some setting they have tried inhaled furosemide also, but there are no certain evidence for that, and even some studies has suggested against the use of inhaled furosemides. Then steroids. Steroids are very commonly used in dyspnea. So how do we decide which steroid and how should we use? So on usually if it is like in bronchial asthma or COPD, we use inhaled steroids as the first step. If it is a lung parenchymal disease, we can use oral prednisolone or methylprednisolone also. Usually doses 4 mg of methylprednisolone to 8 mg methylprednisolone, and if we are using prednisolone, then 5 to 10 mg prednisolone is used. In our settings, in especially the cancers, when there is edema associated with the lesion, or whenever there is airway compression, dexamethasone in higher doses can be used. And also in the lymphangitis carcinomatosis, dexamethasone, so that doses varies from 4 mg to 24 mg per day. So if it is a airway obstruction because of any lesion, it can be at any level. A high dose of dexamethasone should be used. And then anticholinergic drugs usually used to decrease the respiratory secretions like hyoscine or buscopan can be used, glycopyrrolate or atropine can be used orally or IV. Then comes the NIV. NIV use in palliative settings is quite controversial. We have to discuss their choices with the family member. What is the benefit and what can be what cannot be achieved with the NIV also, that has to be discussed with the family member, and then only it's used in some exacerbation of COPDs where there is a lot of CO2 retention is there. The advantage is it is not invasive. There is no need for intubation and all. But the disadvantage is it can be very discomforting for the patient, like that tight mask. Many of the patients feel claustrophobic also, and very uncomfortable on that mask, and the gush of air that goes. And again, if it is the patient is for end of life care, it may prolong the dying phase. So whenever like if it is a reversible condition and a short term or time limited trial of ventilation is required, NIV can be an option, especially in the patients with uh, lung diseases, COPD or bronchial asthma. Then comes the opioids. Okay, so how does opioid works for the breathlessness? Many times it is again a controversial topic, like people feel opioid causes respiratory depression and That's why like it should not be used at all in dyspnea. But there is enough evidence to support the use of opioids in dyspnea, mainly in the refractory dyspnea that is not decreasing by other measures. So it comes as the last step or step 3 of dyspnea management. How does it work? How does morphine work for the dyspnea? So usually, like in MI myocardial infarction, we used to read that it provides the anxiolytic effect and it provides the analgesia in the myocardial infarction. So that's why it is used. Fentanyl or morphine are used in myocardial infarction. So that is means that is known effect of opioid. It decreases the pain and many times because of pain and they have increased respiratory drive. They provide the anxiolytic effect. Very important. They if you remember the diagram, they blunt the afferent transmission from the pulmonary mechanoreceptors, the mechanoreceptors that are there in the small airways or alveoli to the CNS, mainly the cortex, cerebral cortex and brainstem. So those afferent transmission is reduced. It suppresses the respiratory awareness. As I discussed, that there is a mismatch in the ventilatory drive. So it suppresses the respiratory awareness that our lungs are demanding more oxygen, but they are not able to give that much oxygen. So that as awareness or cortical sedation, we call it. So that is reduced. In respiratory centers in the medulla oblongata, there is a transmission, neurotransmission happens, and usually the morphine alters that neurotransmission in the medulla oblongata. It reduces the medullary sensitivity to the afferent receptors from the hypercarbia or hypoxemia. It decreases the overall metabolic rate and thus the ventilatory requirement. And very important, it causes vasodilatation, and that's why it reduces the preload to the heart, and that's why it is used in end stage cardiac diseases or in the heart diseases. So these are the possible 8 mechanisms that you must know about the opioid. If anyone asks why are you using opioids, then you should be able to justify your use. And there are enough evidence to use opioids, but only in the refractory dyspnea. It should not be the first step to start with. But if other measures are not helping, then opioids can be used. The doses of opioids are usually quite less than what we use for the pain. In some diseases like in COPD, even very small dose 0.5 mg twice a day may also may also improve dyspnea. But in some other diseases, like especially in cancer or lung metastasis, the doses are high. So usually here we start with 2.5 mg twice a day or thrice a day, then we increases as required. And this I talked about oral. It can also be used subcutaneously or IV as infusion or intermittent doses. Then and these are some of the other drugs that is used. Those are the bronchodilators. So these are beta-2 agonist, short-acting and long-acting, anticholinergic. Some of the combinations of those drugs, inhaled glucocorticoids that are used. Till now, is there any questions that you want to ask? Okay, we will be continuing then to the non-pharmacological measures. So some of things we discussed. So like fan is like it is very commonly used for the breathlessness, and it's a very easy way to relieve from the distress of dyspnea. How does it work? Although it is not very clear, but they say like there are receptors on the face and nostrils. So whenever the gush of air comes on the face, it gives the soothing effect. So if other things are not available, if even oxygen is not available, simple fan, table fan, just giving parallel gush of wind over the face, that can help. Then there are some relaxation techniques. So those progressive muscle relaxation or guided imagery can be used. Uh, and that has been found to be useful, but patient should be in that condition that he can do the relaxation techniques. If it is associated with a lot of anxiety or requiring some counseling or psychotherapies, that can be involved. Music therapies usually give a soothing effect, and it has been found to improve breathlessness. And there are breathing techniques, breathing training. Again, I said like they count from 1, 2, 3, 4, they hold for some time, and then again during the expiration, they again count from 1, 2, 3, 4. Then comes the acupuncture or acupressure. So acupuncture and acupressure is also found to increase the muscle strength uh, in the patients with MNDs and COPDs, and that's how it improves the breathlessness. And sometimes chest wall vibration, neuromuscular electric stimulations, that has been used again in MNDs or COPD patients. These are few non-pharmacological measures. This is like what are the evidences. So upgoing arrows shows that this intervention supports evidence supports the intervention of this for breathlessness. So like oxygen in hypoxemic conditions, it improves, but in non-hypoxemic conditions, it may not have any additional effect. Opioids, so oral opioids and parenteral opioids are found to be beneficial in breathlessness, while inhaled opioids, there are no very conclusive evidence for that. There are few RCTs that has supported its role, but not in all evidences. Psychotropic drugs and anxiolytics, in some conditions only, anxiolytics has been found to be effective, not in others. There is no evidence for inhaled furosemide or medical gas like Heliox. Rehabilitation, yes, there is good evidence for that. Nutrition in selected patients only, nutrition has helped, uh, especially in end of life patients. Nutrition may not help. Psychosocial support, some breathing techniques, especially the positioning or positive breathing, improves the dyspnea. Okay. And then whenever there is intractable dyspnea or terminal dyspnea, what will be the management? So, like if the symptom is too intractable, then we have to start the sedation for the patient. So, what is palliative sedation? I think if you have covered pain, severe pain, sometimes we have to start palliative sedation, or end of life care. We have to start and palliative sedation. So palliative sedation is to introducing or using the specific sedating medicine, especially the opioids, to relieve the intolerable suffering from the refractory symptoms. Here our aim is to decrease the symptom, not to hasten the death. But usually the patients, if they are toward end of life, they may die, but our intention is to make them unconscious so that they should not feel breathless or pain. It is very commonly used in these three conditions like terminal delirium, terminal dyspnea or intractable dyspnea, or severe pain. Many times it may also be like short for the short time whenever the patient is having severe pain or severe dyspnea. We introduce the palliative sedation, and if a patient improves or their dyspnea improves, we stop the sedation. So, when do we consider palliative sedation? When it is refractory to pharmacological and non-pharmacological options, when death is imminent in days or weeks, whenever there is any other additional treatment is not going to bring any other relief. Uh, Aggressive palliative treatment has failed to improve dyspnea, or it is having intolerable side effects. Our goal is mainly to decrease the distress of that dyspnea, and like when there is not any when the death is imminent, that time we can use. Okay, so this is toward the same palliative sedation. So we need to communicate with the family members that what is our intent and how we be doing it. We have to take the consent, and we have to document our intent why we are doing it. Before starting the palliative sedation, we should correct all the correctable measures, and other measures are not helping, then only we should use. And there should be consensus among the treating physician also. So among your colleagues also, and there should be consensus that nothing else is required and palliative sedation would be appropriate for them. And then we will come to COPD, a very brief of COPD. So when do we call it end stage COPD? So whenever the airflow is limited to less than 30% of predicted FEV1, then performance status is severely limited or further worsening. When there is advanced age, presence of multiple comorbidities, or multiple complications of COPDs are there, then we term it as end stage COPD. So for COPD, how do we approach? So first we start with short-acting or long-acting bronchodilators or anticholinergic therapies. PDE4 inhibitors like theophylline can be used. And if patient is having hypoxemia, supplemental oxygen can be given. If these things are not working, then non-pharmacological measures like exercise, pursed-lip breathing, walking aids, chest wall vibrations can be used. And if nothing else is working, then we have to use opioid therapies. It can again be intermittent or around the clock opioids can be needed. So this is a gold standard framework. So gold standard framework is for all diseases. They have criteria in those diseases when a patient can be referred for palliative care or can be considered for palliative care. For COPD, it is again like if it is FEV1 is less than 30%. If there are recurrent infections because of COPD, at least 2 or more than that, then we can use. If patient is on oxygen since long term, if MMRC grade 4 or 5 is there, sign of right-sided heart failure or corpus malaise is there. Other combinations like anorexia, depression, or previous ICU admissions are there. And patients is on long-term systemic steroids are there. And if any two of these are there, then we can consider them for palliative care. There are others also, general criteria are also there. If one of general criteria and one specific criteria are matched, then we can also refer that patient for palliative care. So this was about COPD and breathlessness. Any questions till now? Okay, then we will go to cough. How does cough comes? So this is pathophysiology. There may be pulmonary cause or extrapulmonary cause. Any irritations in the pulmonary parenchyma uh, can cause uh, cough impulse. So many times the aspirations is there, any infections are there, any pleural effusion or any foreign bodies, any mass is there. Those all things can irritate the lung parenchyma or airways. So, and the afferent nerve from those airways or from alveoli can send the stimulus to the vagus. Many times the reflux from the esophagus or any mass from the esophagus can also send the stimulus to the vagus, and that they may come out as a cough. So for cough, these are possible causes of the cough. How do we treat it? So first of all, it's the correctables. We use the environmental modifications like humidified air or supplemental oxygen if patient is hypoxemic. Any irritants are there, like any perfumes or any smoke is there, that should be avoided. Proper positioning, especially like if a patient is having pleural effusion, proper positioning can decrease, or or any mass that is compressing the airway. In those conditions, proper positioning may improve the cough. Then what are the specific treatment? So those are the antitussive. The rule is if a patient is producing sputum, then we should use the expectorant. If it is a dry cough, usually we use the antitussive or cough suppressants we use. Cough suppressants usually divided into two, centrally acting and peripherally acting. Centrally acting are usually opioids that works in the new receptors in the CNS. Very commonly used drugs are the codeine, morphine, or dextromethorphan. Uh, any one of these can be used depending on the availability. Commonly used are dextromethorphan, that is 10 to 20 mg to 4 hourly to 6 hourly. Codeine and morphine works by the same mechanism. Codeine is metabolized into the morphine 3 and 6 glucuronide, and that how it decreases the cough. Other peripherally acting medications that usually target the sensory afferent from the lung parenchyma. So usually sodium chromoglycate or levodopa, benzonatate usually commonly used, and gabapentin. Gabapentin and pregabalin are many studies has suggested that it can reduce the intractable cough and through the central sensitization of the cough reflex at the CNS level. It also reduces the sensory affluence from the lung parenchyma also. So these are the common drugs. Usually, if patient is having dry cough, intractable, codeine or morphine are the mainstay for it. If it is not working, then we use the peripheral active drugs. Steroids can be used whenever there is edema or airway obstruction. Lymphangitis carcinomatous systemic steroids can be used. And if radiotherapy or chemotherapy induced pneumonitis, especially in those patients who are undergoing radiotherapy to the neck or to the chest, they very commonly complains of cough. In those conditions, steroids can also be used. When patient is having expectorations, mucoactive substances can be used that brings out the cough or secretions in the chest. So Commonly used normal saline nebulizations can be used. If it is a thick secretions, they are not able to bring it out, N-acetylcysteine can be used, or Ondoxil is used. Okay. So these are those symptoms we cover. How much time we have? Uh,
Another 5 minutes, sir.
okay. So we have respiratory secretions, I think, last topics on it. This is especially important during end of life care, when the patient is producing a lot of secretions, and that is causing noisy breathing, and what we call is death rattles, and that causes the discomfort. That at that time it is important to address the respiratory secretions. Many patients, the normal patients also, they have a lot of secretions that may be because of irritation of the airways. So how do we manage it? So there we can use some airway clearance therapies. So for these, patients should be fit for this. So first is active cycles, where autogenic drainage, we try to drain the secretions by the position or posture, or ask them to cough it out, or a forced expiration. Passive techniques is like postural drainage. We percuss the chest or provide the chest physiotherapies. For managing the death rattles, what all pharmacological agents that we use is commonly a hyoscine or buscopan. Glycopyrrolate is commonly used. So why is it important to manage death rattles? Many times patient may not even feel any discomfort because of rattles, but for the family members, it can be very distressing for them to like that sound when the patient is breathing, and they feel like a patient is choking with the secretions, and that's why it's very important for the family member satisfaction that we should manage the rattles. Suction, usually we should avoid suction as much as possible because it can be discomforting for the patients, but a gentle suction can be used. Okay, so this was about the main respiratory secretion, respiratory symptoms that we commonly see.
Thank you, Pankaj. So, Dr. Pankaj has talked about breathlessness, cough, and hemoptysis and congestion. If there are any doubts, please ask. This year,
Here is one question. Acetylcysteine, how to be used for nebulization only, or can be given in the tablet form, oral tablets also?
Which one?
Acetylcysteine for reduction.
N-acetylcysteine, both way it can be used. It can be used orally also. There are syrups also comes, syrups and tablets. So both way it can be used. It can be used orally and also and through the inhaled way. If you feel like it is in the main upper airways, it is, then the inhaled forms helps. If it is in the in lower airways, small airways also, syrups or tablets can be used.
And can it be used for oral cavity secretions when patient complains of excessive salivation?
N-acetylcysteine.
Yes.
N-acetylcysteine usually is not used for the secretions. If it is oral secretions are there. There are other anticholinergic drug that we can use, like glycopyrrolate, atropine, that are commonly used.
And doctor, one thing you told us, gabapentin for cough suppression. In
Yes.
what dose?
Doses means we can start from 100 mg TID, but usually higher doses are required for the coughs and suppressions. Only 300 mg TID is also used.
So one more thing. when we are giving a steroids, Dexona for cough for dyspnea,
Yes,
how
yes.
long does it work? Can we in our patients advanced malignancy? Should it be continued for long?
If we feel like there is any obstruction or any edema or lymphangitis carcinomatosis, we can start with a small, means maybe 3 days of high dose steroids, and gradually we have to taper if there is no further relief. If a patient is having some relief with the steroids, then we can continue at a shorter dose. We can continue. Usually, in any like in any other obstruction or emergencies, we give a trial of higher dose and then subsequently we taper it.
So N-acetylcysteine is a mucolytic agent which is useful when there is copious sputum which is difficult to spit out. So it is a mucolytic. And gabapentin can also be used in a refractory case of cough, which can be started as Dr. Pankaj told, 300 milligram per day and gradually increased. And the maximum dose used is up to 900 milligram. It is not like treatment of pain. So the literature says up to 900 milligram for treatment of cough. And it is not the first line treatment for the treatment of cough.
Any other questions?
Dr. Chirag?
Yes.
Uh, yes.
Dr. Chirag, you are
Hello. Are you?
not
Hello.
clear, voice is breaking. Yes, please.
Oh, now audible.
Yes.
Yes.
Yes. Uh, about the steroids, sir, especially the mineralocorticoids are avoided because all these groups are glucocorticoids because they're causing the water retention in this. But in some patients, we give the depot like a methylprednisolone as a depot, so it can work for the some few days rather than the daily dosage. Sometime in palliative patient, you can we can use as a depot like a methylprednisolone. It is available as a 150 grams. Sometimes we give the IM, so it can work for the they are at the home, so it can work for 5-7 days like that. Because otherwise, if you use the steroids for the more than 10 or more than 2 weeks, there is a you have to slowly taper. But once you use such a depot, it can work for the 10 days for your patient. Is it?
So many patients are on depot methylpred, and usually in those with the parenchymal disease, it is helpful, like end-stage COPD that can be used. But means we are more comfortable with giving oral medications like that. I don't have much experience of depot methylpred, but we have seen
Because
the respiratory physicians using the depot methylpred.
we have a receiving emergency patient with severe breathlessness, and you are discharging and they're coming from the remote area. That time we give the depot for this patient, so they from the severe to moderate, they comes to the mild category of this specifically asthma or some COPD, and then they will follow up. So they have another 7-10 days at home. They have a smooth period. So I asking for the palliative purpose. And as far as the what role of your mast cell modifiers and leukotrienes for the secretion, and this is it their role for the because the and Montelukast, and these are the things which are used for the about
Yeah, Montelukast, I don't means there's not much effect on the secretions or this thing. It is mainly for to decrease like
Inflammation, immediate.
not inflammation actually. It decreases the allergy it reduces the mast cell stabilizer. It is used.
Oh.
So
Thank you, sir.
Anybody else?
okay.
Anybody? If you are unable to ask, you can ask in chat. You can type your questions. Dr. Veda? So if there are no more questions, I think we will move on to patient story. Uh,
Dr. Kichato, you can start.
Okay. Good afternoon, everyone. Can you hear me?
Yes,
yes, you
sir.
are audible.
Okay. Myself, Dr. Kikato, first year resident in palliative medicine from GCRI Ahmedabad. Today, my case presentation on respiratory case. Please, next slide, please.
Doctor, one second. Yes. Can you see it now, doctor?
Yeah, first slide. Yes, now I can see. First slide. Yes. The 66-year-old male, case of carcinoma right lung. Presenting complaint, patient had a cough with expectorant which was yellowish in color for last 1 month. Cough has been increasing more at night, and dyspnea, which is usually associated with cough, and also on exertion. Sleep disturbance because of the constant cough during at night. The patient cannot sleep at night and mostly says he get used to sleep at daytime. A patient has a loss of appetite and generalized weakness and fatigue, which all have been for the period of 1 month. History of illness. Initially, patient had a complaint of pain in the right chest wall, right side of the chest, cough with expectorant, which was initially white in color, and dyspnea on exertion for 1 month. And patient history of smoking for 5 years when he was young, taking 20 to 25 BD per day. Patient was initially taking treatment from private setup and taking some antibiotic and medication which didn't improve. So patient came back to civil hospital here at Ahmedabad. Patient from civil hospital, patient diagnosed with cancer on June 2019, and he was referred to GCRI. From GCRI, patient was given radiotherapy, palliative radiotherapy, first of all seen by brain and thorax surgeon. Patient was referred to radiotherapy department for palliative RT, which given to right lung from 18 to 31 July 2019. Before starting palliative RT, patient was referred to our palliative department for pain management. and patient was started on the second WHO letter, which controlled the pain and other symptoms. Then after palliative RT was completed, patient was referred back to medical onco for chemotherapy on August. But patient refused to take chemotherapy because of a financial problem. Further CT scan, PET CT was not done because of the financial problem. On examination, general condition, moderate, adequate hydration, vitals were stable, conscious and other system were normal. On chest inspection, there is a skin color changes over the lower chest wall, more on the right side and the left side. On palpation, there is mild tenderness over the right lower chest wall, but surface temperature is normal with equal chest movement. On auscultation, basal crepitation on the right side. Next slide, please. Treatment. On treatment and significant investigation, patient have received palliative RT and already on other pain medication from prescribed from our palliative department. Investigation during that other CBC and KF, were normal. After CT scan was done and CT scan show lesion on the right lower lobe involved, there was nodal involvement and involved the left chest wall right, 7 rib with erosion, and also there was involving the adjacent pleura. And patient was sent for FNAC first, which show non-small cell carcinoma, and then sent for biopsy, which came out as non-small cell adenosquamous carcinoma. Sputum examination was ruled out, and other infection was came out to be negative. Psychological aspect, patient, there is no source of income. Patient was initially, he is a daily laborer, whatever he gets to do the job like and earn daily. But since the time of illness, he could not work anymore, and he lived with his wife, and their daily needs are being dependent on his 2 sons, who lives, who are neighborhood, lives nearby, but both sons are also married, and they are also don't have a job. They are also a daily laborer. So his 2 sons is taking care of him, and he has a 4 daughter. Everyone got married, and primary caregiver at home, only wife, and he stays. So wife is taking care of all the household work are being done, and like other taking care patient, bringing hair and getting treatment are being provided by his 2 sons. There is a pollution. Patient, his 2 sons, previously he knew that he had a cancer. After that, when he could not take chemotherapy, has been convinced by his sons that his cancer treatment has already been healed. Because whenever they mention about the cancer treatment, the patient get an anxiety attack and get more worried. So they've been telling him that his disease has been, cancer has been healed, and just is having some cough problem only. On medication, initially, those are the medication that was going on, but he was on a good pain control with tramadol 50 mg TDS and paracetamol 50 mg along with other supportive treatment. But a patient, because of their complaint of dyspnea, it was converted to morphine 5 mg 4 hourly, and amitriptyline was added. Patient has been on a syrup Prosidex, which is expectorant, for the last 1 month. Next. His main concern is, in spite of this expectorant, no patient is having persistent cough and dyspnea. Financial problem, because everyday medication they've been, they have to buy every medication. So we guided for, and patient is eligible to get a Ayushman Bharat Yojana this offer, but we have guided them, but because of their document problem and all, they still have not been able to access. Main concern is another collusion. Right now, the patient has been convinced and like he's okay, he doesn't complain. But if later on, if the patient continue to progress with the disease, like whether we should continue to agree with the patient party or like furthermore have to break the collusion, that is our concern. On summary, a 66-year-old male with CA right lung with persistent cough and dyspnea. Our discussion main point for this persistent cough with expectorant and dyspnea for the last 1 month, what more can be done? Inputs can be given, and since the patient is having expectorant, like whether we should continue to give expectorant for a long term, or if there is no infective etiology, can we give other cough suppression, or what more can be added? And how can we use, like for long term, we can use glycopyrrolate, whether it can be continued, if other have used it successfully to decrease this secretion, you know. Another non-pharmacological aspect, if anything can be done more. We can discuss on collusion problem and also on the financial. Thank you.
Thank you, Dr. Tripathi, for that wonderful patient story. And we have many things to discuss. So here is a 66-year-old man with carcinoma of the lung who is complaining of persistent cough and dyspnea. So I would like all of you to take part in the discussion, and those who are not visible, please contribute in the discussion. So this patient is already on morphine 5 milligram Q4H and Brosedex, steroids, for breathlessness and cough. So what else can be done for treating dyspnea and cough? Those who are not working in palliative care, they can also contribute. How would they manage in if such a patient comes to your clinic or in the hospital? Anybody? If anybody want to speak, please raise your hand.
Or unmute yourself and speak.
We have just now covered persistent cough and dyspnea. We can discuss on those things. Anybody would like to give your opinion?
Dr. Grace.
Dr. Grace, do you want to speak? Dr. Rahul?
For cough, we should add nebulization with saline and steam inhalation.
Okay. So, as a mucolytic, normal saline nebulization and also steam inhalation can be helpful. Okay.
Chest physiotherapy
Mm.
for chest physiotherapy, vibration, chest vibration, useful for
Okay.
draining out patients.
Mm. So, Dr. Kikato, is there plenty of sputum or a little bit of sputum?
Yes.
Yes. Plenty of sputum.
Dr. Siraj?
If the yeah, am I audible?
Yes, you are.
Hello.
Yes, yes.
Is it any comorbid other condition? Is a hypertensive any drugs? Some life. I mean, some AC inhibitors are
Yeah.
going on. Use of the proton pump inhibitors. The lifestyle changes can be done. Some dietary changes for the.
Yeah. Kikato,
He is not on any other medication except which we have prescribed. No history of hypertension.
Okay.
And here the cause of secretion is a tumor itself. It is a secretory tumor. So what we can do is just dry up the secretion, and we have to find out the solution for drying up or expectorating secretion.
okay. So, anybody else? Chirag?
Uh, I. Other than this, no idea.
Okay. Pankaj, what is your opinion how to manage dyspnea and secretion in this patient?
Yeah, here the main symptoms right now are dyspnea and cough. That is borderline with cough with expectoration. So he's a CLN, and in the examination there are crepitations there. But we have done a sputum microscopy, and there is nothing in the sputum. And on the CBC, I think the leukocyte counts are also normal. In chest CT scan, I think we have done no for the mass, and that is suggestive of the masses. One thing like the cause of cough, we have to find it out. Is it only the leoplastic lesion that is causing the cough? Or is there any superadded infection that is not coming in the sputum? But usually the history and our lab investigations are not suggestive. There is no fever, so we rule out any. We will consider there is no infection. But if there is any signs of infection, we should give a course of antibiotics in such cases, especially in the if there is sputum. Other thing is like we are giving expectorant right now, the Brozodex we are giving. Maybe we can consider to increase the dose and see how is it. And we give position as someone discussed, like we can give chest physiotherapy and to bring out the secretions. But if it is persistent and our main goal is palliation of the symptoms, I think at this stage we should uh, consider to decrease the secretions and to decrease the cough. So here one of our question was, should we consider adding glycopyrrolate? Yeah, what's the use of glycopyrrolate? So usually if it is like only the secretions are there, then we use glycopyrrolate for expectorations. I don't have much idea about that, but usually we do not use for the expectorations, the chest expectorations. Dr. Sunil can give some idea if he wants to add in that.
Uh, yeah. And this patient, before going on to whether we are going to add glycopyrrolate or any other anticholinergics, is he comfortable in terms of dyspnea with morphine?
Sorry.
Kikata? Sorry, please unmute yourself. Yeah.
Yes.
Patient didn't have complaint of dyspnea. He was not much worried about dyspnea. Main complaint was cough and expectoration.
Okay. So morphine.
Bit of secretions inside the lungs.
Yeah. So morphine is it reduces breathlessness as well as it is also a cough suppressant. Here what we want to do is it cough suppressant action, or do we need to allow the patient to expectorate? It is a question. So morphine is doing in the opposite direction. It is suppressing the cough. But for the dyspnea management, this patient definitely requires morphine. And I think glycopyrrolate you can try, because it can reduce the secretions. It can dry up secretions. So I hope it can also have some action on sputum production. Uh, so there is nothing inhibiting us from trying with anti-secretory agents or anticholinergics.
So
And
we can use glycopyrrolate here, as Dr. Sunil is saying. Like if it is not infected, and if it is because of the mass or lesion only, we can use glycopyrrolate there also. The second question is like how long it can be continued. So glycopyrrolate as such can be continued for the longer time also. There's no such a period like it should be stopped after these many days. It can be considered as long as patient is comfortable. And input on non-pharmacological aspects that we already discussed, like chest drainage or physiotherapies that can be used, just physiotherapies or those percussion exercises that can be used if some expectorant is not coming out. So with the expectorants, I think if it is not helping, then we will switch to the cough suppressants, and our choice is morphine, as patient is already on morphine, that may be used.
What to do for collusion? Should we break collusion?
okay, anybody from the group want to comment on what to do with collusion? Okay, nobody?
Yeah, one thing. Hello.
Yeah. Chirag.
Yeah, about the cough, because patient having a long history of smoking, looking at the lots of cough, maybe it is a part of the COPD. With the chronic bronchitis, you will get the lots of cough because he has a long history in COPD rather than emphysema. Maybe sometimes the chronic bronchitis is the only component. So just this symptom is really related with the breast cancer, with maybe the chronic bronchitis. So we have give the all kind of treatment, and sometimes the leukotonin receptor antagonist also, because chronic bronchitis they have a persistent cough for the three means such a smoker it can be because here we have no clear cut reason because there is no dyspnea in between, but just to comment about the cough.
Okay, so you are telling that he might have chronic bronchitis, and what can be tried? Uh, you were talking about something which
Uh,
was not clear.
in I have there are the because in sometime in COPD means chronic this is cough smoker's cough where is the already somebody told the good steam inhalation and the sometime the bronchodilators can may work because there is along with the malignancy maybe the uh, lung condition is having underlying COPD problems. So the bronchodilators and the steam inhalation, inhale bronchodilator give you the symptomatic relief even for the removal and suppression of cough. You can easily expect it out.
Okay, so Dr. Kikata, is there a history of long-standing breathlessness like COPD or something else?
Uh,
Smoking.
before there is no like such history. Before he came like come in for treatment, there was 1 month history of cough, chest pain, and dyspnea on exertion.
Okay, okay.
So that is before starting any treatment for cancer.
Okay, thank you.
Because in bronchitis it happens within 2 years you have a 2-3 months continuous episodes of cough. You have a intermittent some months maybe in the history you can inquire just to okay, there are the in a year they have a 2-3 months episode continuously, then they are fine in between, then just for the
Okay, thank you, Dr. Chirag, for your input. The next question was whether we need to uh, do something with pollution. Anybody would like to comment on whether we need to break the pollution or what shall we do with this patient? Because the patient's son says there is panic attacks when he hear about cancer. Anybody? Okay. Pankaj, what shall we do on this patient?
Dyspnea, sorry, collusion is a very common problem. Like in our setting, almost most of the patients, family members want to hide the information with the patient, and many times it's challenging for us to break the collusion or handle the collusion. I should not say the break. So first of all, as we should ask the family members why they are worried. Here you told like they feel the patients will become means has a anxiety, episodes of anxiety. So then next thing is like we would like to perceive the information from the family members. What do you think the patient currently knows? What is their knowledge about the disease? Or we can ask the patients also sometimes during our discussion, what patients already knows about. Many a times patients knows only thing like nobody is discussing, no one is asking the patient about this thing. Many times family members are afraid that if patients become very anxious, how will we manage, like it will add on the physical symptoms for the patients, these psychological symptoms. So we have to provide the psychological support to the family members, and we have to tell them the disadvantage of having collusion, or what we can do if we break the collusion. Why is it needed to break the collusion? These are the main things that we have to keep in mind, and we have to tell the patients, family members.
Uh, I think the GCRI team is looking at the patient son says he will be anxious when you talk about the prognosis. So whether they should go and break the collusion and tell the patient that you have recurrence of cancer or not. That's what they are looking at.
So this is like they should ask the patients, first the family members, how much they know, and then if the family agrees, like we have to break the collusion, and if we want to tell the patient, then again we ask the patients how much they know, and whether really, if he doesn't know, whether really he wants to know how much he wants to know. Uh, that is
Okay,
it.
Dr. Tikato, does the patient know that he has cancer?
The patient earlier, he know that he has a cancer, but after chemotherapy has been refused and started only on a palliative medication from our department, his sons convinced him that his cancer is already been healed. So he's convinced that with radiotherapy, maybe he has healed.
Okay. So patient son doesn't want to break the news that he has recurrence of lung cancer because
Yes,
the son feel that he will be in anxiety, isn't it?
yes.
Okay. So I think we should empathize with the caregiver that yeah, we should empathize. You are very much anxious that we are going to talk about the disease, something like that, so that they will feel that we also understand the situation. And does the patient actually ask you about whether he want to know about the disease status as of now?
No, no.
No. But what do you think? Does he want to know what is your feeling?
He doesn't look like he's been curious about his cancer.
Okay, so here, as Pankaj told, we have to empathize with the caregiver, and if we want to go and tell the patient, we can assure him that we will do something which can make the patient to reduce the anxiety. Maybe if he has past history of such panic episodes or chronic history of anxiety, then maybe with SSRIs, and if there is panic attack as such, maybe benzodiazepines might be used. And you should ask the patient, go and ask, what do you think, why you have this recurrent cough and breathlessness? And if he shows, or if he then, if he is interested to know why he has these problems, then with the consent of the family, we should go and tell the patient that you have recurrence of the malignancy. But it is very difficult in this situation, because the son is very particular about the anxiety which can be precipitated by breaking the news to the patient. But if you want to go about this, I think it is important for the patient to know if he wants to know about the disease. So I just want to add a few more points that in case of cough due to malignancy, there are some guidelines from journal of chest, which they says if there is cough, the first step is to use demulcents like menthol or something. Then the second step would be opioids. Then the third step is some peripherally acting mast cell stabilizers like chromoglycate. And then comes there is a role for local anesthetic, nebulized local anesthetic like lignocaine or bupivacaine. And in the next step, they are suggesting gabapentin or pregabalin or even amitriptyline. So in this patient, the chronic cough most probably might be because he has a lung lesion. So that is irritating, and that can cause cough, which usually produces some amount of sputum. So maybe I think even you can try to increase the dose of morphine, and sometime it may help to suppress the cough, and thereby the irritation will be reduced, and the cough will be reduced, and secretion will be reduced. Um, so this is another point I would like to make in this patient. Pankaj, do you want to add anything else? Please unmute yourself. Yes.
I think most of the things we have covered, like the sodium glycolate that I forgot to mention. That is used.
Okay. So, Dr. Kikato, do you want to ask anything more in this patient, or do you think anything more to be discussed?
I think this will do.
Okay. So, thank you, Dr. Pankaj, for being our faculty today and handling such an important session. And Dr. Kikato and GCRA team, you have managed this patient very well, and we have given a few suggestions which you can try, and maybe it will be helpful for us to know what happened to this patient maybe later during this sessions. Thank you for presenting this patient story, which was very relevant. Thank you all for participating today's session.
So we can see you on next Thursday with session of wound management taken by Sister Shiva. So thank you all for joining in. So we have shared the feedback link. Do the feedback and leave the meeting. See you on next Thursday. Thanks.